All right, we are concluding with this last session for SVTs. When a patient is coming in for a cardiac ablation, it's like we are doing a cardiac cath or an angiogram or an angioplasty or an arteriogram. And I wonder why I'm giving you all those words, because once the nurse knows that a cardiac cath, a cardiac ablation, an angioplasty, a stent, any of these PCI, PTCAs, they're all done the same way, thank God, which means that this patient will get some type of anticoagulant so the patient's blood doesn't clot during the procedure. Contrast dye will be used, so you'll have to remember those kidneys and to flush with plenty of fluids and to check for those iodine allergies that some people say don't matter. And as we position this patient for this procedure, keep in mind, we could use one of two routes, but the most common route is going to be the femoral area of the patient. So we're going to watch our physician thread the catheter through the femoral vessel and go all the way up to the right side of the heart, enter that atrium, and then take those probes or those catheters and zap the area of concern. The very area that's actually causing all the drama is where we're going to apply in the physician's situation. They're going to apply like microwave type heat, and then some sources say they've been starting to use some freezing or cryotherapy. But for the purpose of this lecture, let's keep it simple. We're just going to send a microwave type heat to the area that's causing all this crazy rate abnormalities, and it's going to zap it or burn it and kill it and make the cells in that area die. And then this patient will not have these episodes of SVTs anymore. I have a delightful young lady who described the procedure for the class and said she's been great ever since. She's gotten married, just had a baby, has been a nurse for years. Shout out to my girl, Jill Guilfoyle, woohoo! Now, so this patient is going to go ahead after this procedure, and the nurse has to watch this patient very well. They can't sit up. They have to keep the extremities straight for 6 hours. You've got to really monitor the site for any bleeding. They may put sandbags or an ice pack on it. The patient, if they call out and they say, hey, I think my ice pack is leaking, that's not an ice pack. That is blood. You get your butt in there right away. This is a hematoma, and the nurse knows to put pressure above the site. But if everything goes well, then this site of where we put the catheter through should be fine. Now, the key is checking those pedal pulses and doing your neurovascular checks to make sure this patient is fine and the stitch doesn't pop. The other issue is, remember, we did give this patient an anticoagulant. There is a tendency to bleed, so we have to really watch them. Now, lastly, this patient will most likely be discharged home on aspirin and or a NOAC, a new oral anticoagulant medication. I hope this helps. God bless. Till we meet again.